we'll start with, and the risk, lowest risk, oh, I can't, oh, interesting. Okay, my head's going to cause my own shadow. Lowest risk, highest risk. Highest failure rate, lowest failure rate. Can you guys see that, or is it just a big bunch of blubbery up here? You can see that? All right, okay. So we're going to start with the lap band. The lap band, esophagus, stomach, small intestine, is basically, do we have one of them here?
No, but
okay.
Want me to grab one?
She's going to go grab one. We'll hand it around. It's a lot of fun to play with. It's a little inner tube, basically, that I put around the top of the stomach that's connected to a little tubing that's connected to a port that's buried under the skin. And that inner tube, I can inflate, which tightens it, or deflate, by placing a needle through the skin into the port and adding saline, or water, if you will. So if I add saline to that, it tightens the band. The band sits around the top of the stomach such that when we eat something, it may fill the top part of the stomach, and the rest of the stomach doesn't get full, but the receptors, the nerves at the top of the stomach stretch, and they tell the brain, oh, you're full. Before that, we had to fill the whole stomach before those would stretch. Does that make sense? Also, when you put something on the stomach, it tells the brain something that, and it doesn't get hungry as much. Okay, so you don't really feel hunger the same way. So it restricts the amount that you're able to eat, and it helps with hunger feeling. Now, I can make this real tight and people won't lose a pound. Because if they drink high-calorie liquids, sodas, alcohols, ice creams, that'll go right through, even if it's tight. And people, the nice thing about the band is that it's adjustable. And the bad thing about the band is that it's adjustable. So people will go, they start that whole psychological game of, well, if I have more fluid, I'll lose more weight. But that's not the way it works, because you can get more fluid and not lose weight. So it's important to get the right tightness. And that can be tough, especially if people aren't doing everything right, if you know what I'm saying. So that's called the lap band. Band. Okay, it's the simplest to perform. It's an outpatient procedure for most people. They come in, we can place the band, it takes under an hour to do, and the patient can go home that day. Okay? Now we'll move over to the Cadillac, which is the duodenal switch. We'll call it the DS. And this is the most malabsorptive procedure. It takes the longest to do, and it has a higher complication rate. The duodenal switch, esophagus, stomach, pylorus, duodenum. Pylorus is the little valve at the end of the stomach. The duodenum is a very special place. Okay? This is where the bile and pancreas enzymes join with the food to start breaking down the food so we absorb them. So what I want to do is separate the food from the enzymes and let them come back together downstream somewhere else so they can start that process later, so we don't absorb all the way. What we'd start with is what's called a sleeve gastrectomy, where we remove this part of the stomach. And we basically make the stomach like a long esophagus that has a little valve at the end. That creates restriction. Okay? Then I divide the duodenum so that food doesn't get to here. But I have to have the food go somewhere. So I divide the intestines down here. I bring up a piece of intestine, attach it to there, and then reattach it to itself down here. And then this goes to the large intestine, colon. So food comes down this way, and enzymes go down this way, but they don't start absorbing until they get together here in what's called the common limb. So the common limb, in this case, is about 100 centimeters long. It's short. So I'm creating a short landing strip, if you understand what I'm saying. So the calories that you eat, you have about that much space to really absorb them, and then they go out in the toilet. So if you eat things that have a high fat content, you might have diarrhea. Okay?
Explosive bowel diarrhea.
Thank you. Peanut gallery. So this procedure is the most malabsorptive procedure, has the least amount of restriction, but does have restriction, has the best weight loss and the lowest failure rate, but has the higher risk because there's a lot of activity and staple lines and suture lines and dividing and putting back together. Now back over towards this half again. You already saw what I called a sleeve gastrectomy, and that is its own operation for restriction. And basically, this, I removed this part. This procedure evolved because when they started doing this procedure laparoscopically, the mortality rate was too high. They said, that's too high. We shouldn't be doing it this way. Let's do half the operation. They'll lose weight with the restriction and come back another year and do the second half of the operation. Well, they found that doing half the operation worked really well. Well, more so than they thought would. And so the weight loss with just doing the sleeve gastrectomy is enough that people will have just that procedure done and only have that procedure done. It's okay. So this is called the sleeve. Oh, it's 2 E's, 3 E's total. 2 in the middle, 1 in the end. Okay. This procedure is purely restrictive, although when we get rid of this part of the stomach does produce some enzymes that it's called ghrelin that affect our brain and make us think we're hungry, etc. So this is a little bit more than just restrictive. Its weight loss is better than the band. Okay? The failure rate is higher than this. And when I say failure rate, we'll say 30%. 30 to 40% with this and 30% with this. And it's usually about 3 or 4 years later, this can dilate out a little bit. The good news about this procedure is that if someone were to fail, 70% don't, if someone were to fail, I could convert them to this at a lower risk because their weight's down. Or I can convert them to what I'm going to do next, which is the Roux-en-Y gastric bypass. So now, I'm going to draw the Roux-en-Y gastric bypass. This is the gold standard operation done in this country. In the world, the Roux-en-Y and the band are the number 1 and 2 procedures done. This procedure goes like this. This is the one that Al Roker had. Esophagus, stomach, small intestine. In this procedure, I make a little tiny pouch out of the top of the stomach and separate the stomach from the pouch. That pouch is about the size of a small egg. So food won't go in here anymore. And just like this procedure, I need the food to go somewhere. So I divide the intestines, bring up a limb, connect it to the pouch, and reconnect it to itself down here. This is called the Roux limb. It goes up and over the stomach like a bridge, bypassing it. Hence the name, Roux-en-Y gastric bypass. Surgically, this is a Roux-en-Y reconstruction, but it's not a gastric bypass because we're still using the stomach. We're not bypassing it. So in this procedure, the pouch is a lot smaller than the sleeve. So there's more restriction. But the common limb is a lot longer. So it's about 300 centimeters of intestine that you can absorb over. So the risks of surgery would be bleeding, injury to intestine, leak. Wherever I cut things, it could leak. Okay? Blood clots can happen in people's legs when they're in hospitals. If those blood clots go to people's lungs, that's called a pulmonary embolus. And all those things can kill people. Okay? Hernias can happen in incisions, a lot less common than laparoscopic incisions. We always reserve the right to make the incision open for your safety, because your safety is the only thing that matters. And for the most part, the risk of dying should be less than 1 in 100. Should be less than 2 in 100. Should be less than 1 in 200. Should be less than 1 in 300. Okay? But generally, it's like 3 in 1,000 to 9 in 1,000. Or you know what I'm saying? It's 3 times as risky, but it's still less than 1%. Does that make sense? Statistics can get very confusing. So the complication rate might be 3 or 4 or 5 times as high as this procedure, but your death rate should still be less than 1 in 100. That's still important to that one. Okay? Failure rate for this is generally about 15%. 15 out of 100 will find a way to gain weight. Okay? And we expect about a 60 to 80% excess weight loss with these operations, specifically the stapling operations, in about a year to year and a half. And that means if someone's 100 pounds overweight, we expect them to lose 60 to 80 pounds. If they're 200 pounds overweight, we expect them to lose 120 to 160 pounds. That's what that means, okay? So, a common question is, what makes you think of one operation for someone and one operation for someone else? For people with diabetes, we have found that when food doesn't see the duodenum, people's sugars normalize very quickly. Many patients who come in on insulin may go home on no medications from the hospital. If someone's been a diabetic for a long time, they'll probably still need some diabetic medications for a while, but about 80 to 90% of people who are diabetics will come off of their medications eventually, and that's very important. People come off diabetes issues with these 2 procedures also, but the weight has to come down first, okay? So it doesn't happen as quickly. People with bad heartburn or reflux, if they have the band, that can worsen that. The best procedure for someone with bad heartburn or reflux is this procedure, because the stomach is separated from the bottom of the esophagus, so you don't get acid going that way anymore, okay? If somebody has a problem with ulcers of their native stomach, or polyps, or something that makes people worried about not being able to see that anymore, I wouldn't want to do a Roux-en-Y, because I can't get in there from the mouth. So I would say they should have one of the procedures where we either remove the portion of the stomach, but that we're able to endoscope and see the whole stomach anytime we want. So there's a bunch of different reasons why different procedures might be better for other people. The most important thing is that we don't tell people what they should have. People will come in and say, Uncle Joe and Aunt Martha had the Roux-en-Y and that's what I want. Well, then that's what you're gonna get, because if I talk into something else and there's some, the family dynamics of that is just not something I want to deal with, okay? I won't generally talk somebody into a more risky procedure. They come in and they want the band, I'm not going to talk them into a switch. I might talk someone into a less risky procedure though, okay? And everybody has their own risk profile. Everyone has their own hand of cards.